great opportunities and work happening here in the Commonwealth. If you have questions or comments, there are mics in the hall, in the aisle. If you would move to those mics if you want to share a comment. I think what I heard out of this was kind of a theme of data, obviously, policy, process, and outcomes to health improvement, and that it's really the collective action of bringing together not just the data analysis, but the translation of that information so that it's useful in terms of looking at the whole dynamic of the populations that are trying to be, that we're targeting to serve for health improvement, that it does take understanding the social determinants of health, and so bringing in the housing, the transportation, education, income factors are all very relevant. And that data is now, I think, at the forefront instead of in the background of looking at, of it not being an afterthought of, well, do we have the numbers? Many meetings start out with, what are the numbers before, and so having that information in a very friendly and compatible format is necessary as well. So we have someone at the mic.
Yes, hello. Question is for Chris regarding the electronic medical record and release to the local health departments. Any timeline, ideas? Can you just give me a ballpark?
Sure. The project is well underway, and actually we piloted a dental component at a few key public health departments, and it's been extremely successful, very well received. So we're very excited about demonstrating success and value through the dental pilot, which the director for Clark County was here earlier and touching upon how they're bringing oral health particularly into the school system. And that's exactly what we'll be doing with electronic health records actually at the schools where we did these pilots, and it's worked very well. So we'll be rolling out the electronic health record across, and you heard Scott say 61 public health departments in each of the 120 counties. So this is a big, important project, but the rollout will start, I believe, in earnest in March of 2016 and roll out to the health departments in 2016.
Other questions, comments? Maybe I'll ask Glenn to say a little bit more maybe about the collective impact or collective action work of working across and vertically, horizontally with many stakeholders.
Yeah, well, I think one of our experiences is that people, stakeholders, even those who work in healthcare and public health, don't realize how interorganizational and multi-sectoral a lot of our work is, especially as we move upstream into prevention and public health. And that's one of the reasons why we created our surveillance system, is to actually capture data on that. Who contributes to a core set of public health activities and prevention activities? And how do those organizations and those contributions change as we move across communities? How do they change over time? So we can visualize that, so people can really see this is not just a health department program. This is not just a program being operated by our community hospital, but who's doing diabetes prevention? Who's doing infectious disease control? Who's doing environmental health monitoring? Let us visualize these multi-sectoral roles, and then we can figure out where the opportunities for improvement is, and where we can leverage some of those relationships to move into other areas and other program and population needs.
Thank you. Teresa, any final thoughts you want to share with us?
I guess just the final thought that I had is, and I think both of the speakers did a good job of showing that this is a whole ecosystem, and that you need to have systems behind the work that's going on to make sure that it persists, and that we really can drive impact within our communities. It's not just about the data or the individual projects, but creating really a network that is going to sustain this type of work going forward. And you don't want to see that go out with a new political administration, because often that can happen when you have changeovers in terms and in elected officials. And so the work that we've done in Louisville, I know the work that they're doing at the state really is with the intent that that doesn't happen, that this does persist because it needs to, because it is so critically important to the health of individuals. So.
Sure, thank you. And just one final thought or idea that comes to mind in terms of public-private health systems work. Are any of you working with health systems with looking at data sets and sharing of data? No one yet?
Yes. How's that? No, the partnership with UK and really hopefully what becomes a broader partnership, recognizing the universities provide a lot of care through the medical centers. We'll certainly be sharing data with those entities. And again, I point to the private payers, and I did so sort of jokingly. They have a lot of legitimate concerns about their data and where that data goes and how it gets used. So we are very hopeful about the interaction that we've had with private payers in particular, and we believe we can demonstrate the value of them participating with us in the Health Data Trust and consider other policy levers that we might need to consider along the way.
Okay, thank you. No other questions or comments? Let's give our panel a hand of applause. Thank you, and I believe we're ready to transition.